Hi, my name is Dr. Ruchir Patel. I'm a sleep medicine specialist with formal training in sleep medicine with a background in internal medicine, but also special focus in neuromodulation therapies for sleep apnea as well as insomnia, but even mental health. Let's talk about sleep.
This podcast is brought to you by Sip to Sleep. SIP, the number 2, sleep. Sip to Sleep is an all-natural, patent-pending, clinically proven natural sleep aid without melatonin. It contains 2 natural ingredients, tart cherry extract, which has been shown independently in small clinical studies to improve the ability to fall asleep, stay asleep, and sleep longer, but without the natural sugars of the tart cherry juice. And then the second ingredient in Sip to Sleep is Venetron, which is rafuma leaf extract, which comes from Japan. It has been shown independently in clinical studies to improve the brain's ability to enter into stage 3 sleep, which is also known as deep sleep, but also reduces degradation of serotonin in the blood, which is a precursor to melatonin, but also helps to improve mood by virtue of having antidepressant and anti-anxiety effects. Both of these natural ingredients combined together actually help to facilitate increased natural melatonin production and release from our brains, which in turn helps to facilitate sleep. The clinical study that was run on Sip to Sleep, specifically in 2023, showed that greater than 80% of participants that took Sip to Sleep prior to bedtime found that they actually fell asleep faster, slept longer, felt better rested the next day when they woke up in the morning and during the daytime, but they also noted a reduction in next day anxiety as well when they took Sip to Sleep compared to not taking it. So if you're looking for an all-natural sleep aid that does not contain melatonin and does not have the negative long-term effects of prescription sleep aids, try Sip to Sleep. It's formulated by a sleep physician. It's available online at www.sip, the number 2, sleep.com. That's www.siptosleep.com. Do you have problems falling asleep or staying asleep or just waking up early in the morning and can't turn your mind off and get back to sleep? My name is Dr. Ruchir Patel. I'm a fellowship trained full-time sleep physician. Let's talk about chronic insomnia today. So chronic insomnia is something that a lot of individuals will kind of loosely say that I've got insomnia, right? Insomnia is probably the most common buzzword in sleep medicine. I believe at one point it was the most commonly Googled search term as well. But insomnia has a very specific definition. So by definition, chronic insomnia has to have occurred for at least 3 months. Symptoms have to occur for at least 3 days per week, but even the symptoms are actually very characteristic as well. So by definition, according to our guideline books on terms of diagnosing chronic insomnia is defined as having either difficulty falling asleep, difficulty staying asleep, early morning awakening, which is defined by waking up at least 30 minutes prior to your desired wake time, non-restorative sleep, difficulty or resisting going to sleep, which is more common in pediatrics. But then the insomnia symptoms must be associated with some kind of daytime impairment as well. And that could be, waking up tired, daytime fatigue, daytime sleepiness, even issues with mood, problems with daytime functioning at work, memory issues. In the setting of children, it could be hyperactivity, irritability, agitation. And then, like I said, the symptoms must occur for at least, 3 months. They should occur at least 3 days per week. And then also the symptoms of insomnia or the problem sleeping and the daytime symptoms can't be attributed to inadequate opportunity or inadequate environment for sleep. Also, the symptoms of difficulty sleeping as well as the daytime symptoms can't be explained by another sleep disorder, mental disorder, medical condition, or neurological condition or medications. So that's the official characteristic or guidelines or criteria for diagnosing chronic insomnia. Now, other risk factors for chronic insomnia can be medical conditions, such as a history of diabetes, cancer, issues with your heart, such as history of heart failure, uh, angina, hypertension. It could be history of cancer. It could be chronic pain syndrome, secondary to fibromyalgia, or it could be secondary arthritis, or it could be even secondary to, herniated disc that just can't get completely resolved. Even hyperthyroidism or overactive thyroid can cause insomnia symptoms. Even urological issues such as frequent nighttime awakening for going to the toilet or nocturia, as we would call it. So there's several different medical conditions that can increase the risk of you developing insomnia. Even COPD and asthma also can be risk factors for developing insomnia. But then there's also neurological conditions such as Alzheimer's dementia, Parkinson's disease, a history of traumatic head injury or brain injury, history of seizures, history of headache syndrome, such as hypnic headaches, where individuals will wake up with headaches in the middle of the night, or even early morning awakening headaches when you first wake in the morning. But there's many different other neurological conditions that can also predispose you to chronic insomnia as well, even chronic peripheral neuropathy that causes chronic pain. Then there's many medications that also can predispose to insomnia as well, such as bronchodilators, which are inhalers that are used to treat COPD or asthma. They can actually increase heart rate. They can even trigger anxiety as well. But then even beta blockers, diuretics, caffeine, alcohol, steroids, central nervous system stimulants or central nervous system depressants. And then, of course, there's various different sleep disorders that can actually present with symptoms of insomnia as well, such as restless leg syndrome, which can often cause difficulty falling asleep, or it can even cause difficulty getting back to sleep in the middle of the night. A related condition called periodic limb movements during sleep, where you have these involuntary leg movements or movements of your feet while you're sleeping, which can keep waking a person up. Many of these individuals also have restless leg syndrome, so when they wake up, then they have difficult time getting back to sleep because their RLS symptoms bother them. Sleep apnea. Sleep apnea is a very notorious sleep disorder that can actually contribute to insomnia symptoms, both difficulty falling asleep, difficulty staying asleep, and even early morning awakening as well. But then there's many different circadian rhythm disorders. So circadian rhythm, of course, as I mentioned in a previous podcast, I spoke about jet lag. It's basically your intrinsic bedtime and wake time, right? That's that pre-program kind of clock in our brain that determines what time we go to bed and wake up. Well, there's a condition called delayed sleep phase disorder where an individual's circadian rhythm is actually set for them to be a night owl. Or there's another one called advanced sleep phase disorder where an individual's circadian rhythm is set for them to be basically a morning lark or wake up early in the morning, but they go to bed early in the evening. Jet lag, individuals that don't have light perception, often in blind individuals, there's a circadian rhythm disorder called non 24-hour circadian rhythm disorder, where their internal clock basically has lost the entrainment with the light cue. So, as a result of their brains not being able to get information from the retina detecting light, the brain actually doesn't know, or the circadian rhythm actually doesn't know when the sun is out and when the sun is down. So, in that situation, the internal clock just kind of rotates in a clockwise fashion. So every night there's a different bedtime. But then jet lag, as I mentioned, is also another notorious risk factor for causing insomnia as well. So as you can see, that insomnia is not just a simple diagnosis. So for a sleep specialist, when a patient comes in complaining of, I have insomnia, well, in our minds, we have to think about all of these different things that I just discussed, right? So it's not just a matter of I can't fall asleep, right? For us, when we meet a patient in clinic with I can't fall asleep, or I can't stay asleep, or I'm waking up early in the morning and I can't get back to sleep, in our mind, we have to figure out, well, is this an acute insomnia, which is actually defined as an adjustment insomnia, which can occur for many reasons, right? So when an individual loses their job, when an individual loses a loved one, any kind of psychosocial stress or financial stress, you name it, moving, anything can trigger a person to have new onset insomnia, where because of the acute stressor, they're having a hard time relaxing their mind. But once that acute situation resolves, typically that adjustment insomnia will also resolve as well. So by definition, adjustment insomnia is individuals that are having insomnia symptoms, but they resolve within 3 months. Chronic insomnia, like I mentioned earlier, is once the insomnia travels across that 3 month mark and at least 3 days per week, that's when we define it as chronic insomnia. So when we're meeting with patients in clinic, we kind of go through and do a very complete sleep history, so to speak, but we also have to review their medical history and their medications as well. But then also talk about when did the insomnia start? What were the surrounding factors around it? What's been perpetuating the insomnia? Because once an individual develops insomnia, it's a very paradoxical situation where individuals don't have to think about sleeping. So when people are sleeping well, if you ask them, hey, do you put in any effort to sleep? It's like, nah, I don't even pay attention to myself sleeping. I sleep well. I don't have to think about it. When it's 9:30, I turn the TV off. I put away my phone, turn the lights out. I put on my CPAP mask and I'm out within seconds, right? If I wake up in the middle of the night, I roll over and go straight back to sleep. I don't have to put in any effort to sleep, which is unfortunate. Though I had, insomnia issues many, many years ago. So I know what it's like to have chronic insomnia. But in individuals that actually start developing problems sleeping, it depends on their overall attitude towards sleep, right? Most individuals, after several nights of poor sleep, they'll start paying attention to it, meaning that, hey, wait, why am I not falling asleep quickly? Why am I so restless during the night? Why am I waking up early in the morning? And then, of course, when they start having daytime symptoms like fatigue and tiredness or poor short term memory, poor concentration, and even mood issues, that's when individuals start kind of paying more attention to their sleep to try to figure out what's going on here, right? And most individuals, by the time they come to us, they've already tried multiple different things on their own, right? They've probably gone online and or gone to the pharmacy and bought over-the-counter sleep aids. Melatonin probably is going to be the first one that most people reach for. They've also tried alcohol, which is a big problem. But they've tried many other things, even online, using different apps or Googling and kind of trying to self treat their issue to be able to see, can I just resolve this on my own? Right. But what ends up happening for many individuals is that they start putting so much focus on trying to correct their sleep issue or their insomnia that now sleep went from something that they never had to pay attention to, but now sleep is on this kind of mountain peak where every day they're trying to climb up to that mountain peak to get sleep, right? Sleep is not something that's meant to be um, effortful, right? It should be effortless, meaning that we shouldn't have to put an effort to try to sleep. But once it breaks, everyone or many individuals will go on this mission of trying to fix their sleep. And the harder you chase after your sleep, paradoxically, the worse your sleep will continue to be and the longer the insomnia will continue. So it's always important that if you start developing insomnia symptoms, and if after a few weeks it hasn't resolved, reach out to your physician to get assistance or seek out a sleep specialist. It's better that you address it early than let it evolve into chronic insomnia because I've met patients in clinic that have had insomnia for 40 years, right? And they had tried multiple different things. Most often, they tried the over the counter things early in the insomnia history, but then they went on a path of, being prescribed various different prescription sleep aids. And one may work for a while, then they go to another one, to go to another one, go to another one, but no one actually met with them to go through and actually figure out what's actually causing your insomnia. What was a precipitator? What's been the perpetuating factor? And what's preventing it from actually resolving? And there's an important 3P model for chronic insomnia, right? Three P's, P's and Peter. So all of us have a predisposing factor that at some point in our life cycle that we will develop insomnia. Then there's a precipitating factor, which there's some trigger for us to develop, difficulty sleeping. And then there's perpetuating factors. And the perpetuating factors are what causes the insomnia to become chronic, right? One big one that I mentioned just now was individuals now becoming hyper focused on trying to correct their sleep. That's a big, big perpetuating factor. Now, a very common perpetuating factor is individuals have a tendency to just lay in bed, not falling asleep, right? So, for instance, you take an individual that went from not having a problem falling asleep. Now they're under high amount of stress. They've developed anxiousness for various different reasons, whether it's work related stress or family, financial, it doesn't matter. But ultimately, the person is anxious and stressed to where when they get into bed, they have, a bad night where they're just laying there thinking about all these things that are making them stressful and anxious. And it takes them 45 minutes to go to sleep, right? Whereas normally they'd fall asleep within 20 minutes. Well, the next night comes and they're still laying there with their mind racing and they're taking an hour to fall asleep because they just can't stop thinking about all these things that's causing them to be stressed and anxious. Well, fast forward to say a month later, now the acute stressful situation has resolved. That's passed. They've had resolution with it. They're no longer anxious or stressed about it, but their brains won't allow them to get to sleep quickly. So when they get into bed, before a month ago, they were able to fall asleep within 20 minutes. But now, even if they're not stressed and they're not anxious, because all that situation, basically completed and finished and resolved, Now they're just laying there thinking about different things. What do I need to do tomorrow? Do I have time to go to the gym? Do I need to pick up groceries tomorrow? Did I check my email on this or did I respond to this person? Now they're just thinking about various different things. And again, it takes an hour for them to fall asleep. So what I'm getting at is that what ended up happening is that individual in the beginning was laying there, letting the mind race and think about things that were causing them to be anxious. Because they did it night over night, overnight, overnight, well, the brain ended up learning a new habit, right? Which is, hey, we're tired, but we don't have to go to sleep right away. We can get into bed at the time that we normally would, and at the time that we would normally fall asleep within half an hour. But now we're just going to lay there and think about mindless things, things that we could think about tomorrow. We're going to think about it now. And the person self perpetuated the issue because they kept laying in bed beyond that 30-minute mark, just laying there thinking, right? So, what ended up happening is the brain learned a new conditioned response, which is get into bed, but we don't have to fall asleep right away in bed. We'll lay there and think about things. And that's a very common thing that people will do. I was in California this past weekend. I met with someone, and one of the first things he said was, "Gosh, I wake up at 3:30 in the morning, and it's like my mind just wakes up and I'm just laying there thinking about all sorts of business, different things, and I can't turn it off and I can't get back to sleep. Like ideally I'd want to wake up around 6 or 6:30, but I'm waking up at 3:30 and I just can't turn it off. I don't know what to do. But I just lay there for an hour, hour and a half, just thinking about various different things. My mind's going 1,000 miles an hour. Well, this gentleman actually has been self perpetuating his early morning awakening insomnia, which we used to call terminal insomnia. But he self perpetuated it because he's been feeding his brain the ability to just lay there and think about various different things, right? So that's what I mean by many individuals will actually self perpetuate their issue. But then the other thing too is he kept telling me, he's like, gosh, it's like my brain's now programmed to just wake up at 3:30 in the morning, no matter what time I go to bed. Again, that's a conditioned response. The brain has learned a new habit towards sleep, which is wake up at 3:30 in the morning, boom, and just lay there, start thinking about various different things. How can you break that cycle? Well, in cognitive behavioral therapy for insomnia, which is the gold standard way of treating chronic insomnia, typically performed by sleep psychologists, there's a principle called stimulus control, right? This is a very cardinal principle in CBTI. And what the principle of stimulus control states is that if you're trying to fall asleep, regardless of whether it's in the beginning of the night or in the middle of the night, if you haven't fallen asleep within 20 or 30 minutes, get out of bed. Don't continue to lay there. Get out of bed, go to a different part of your home, dim light, read something on paper, not electronics, right? The blue light from electronics and color screens is going to basically start inhibiting melatonin release, which is not what you want in the middle of the night, right? Melatonin, of course, is our main sleep hormone. But sit there quietly and read something on paper that would normally make you yawn or tired during the daytime. Don't pick up a book that you're excited to read and you want to spend the whole night reading. That's kind of counterproductive. Or even engage in breathing exercises, meditation, progressive muscle relaxation. The whole intent being is that you're trying to distract your mind away from the fact that you're not asleep in bed, right? And the other thing too is that we don't want you to be in bed doing these things because as sleep specialists, we tell everyone the bed is for two things only: sleeping, having sex, right? That's it. The bed is not a place to be awake. So we ask individuals to engage in the stimulus control principle because the whole intent is that we're trying to distract the brain away from the fact that it's not asleep in bed. Yes, you're awake, but you're awake somewhere else. So you're trying to reestablish that association with the brain in that we're only going to lay in bed when we're going to sleep. If we're not asleep, we're going to be awake in this other area of our home, right? So you're basically trying to retrain your brain to know that the bed's only for sleeping, right? We're not going to lay awake in bed. And it's a tedious principle. We get it, right? But it truly does work. And in the beginning of the night, if you're having a problem falling asleep after about 20 minutes, get out of bed. If in the middle of the night you wake up at 3:30 in the morning, like this gentleman I was referring to, and you haven't fallen back asleep within 20 minutes, get out of bed. Once you start feeling drowsy, then you can go back to bed and go back to sleep, right? So we want basically the brain to see that, hey, when we get back into bed, we're falling asleep really quickly. So over time, the brain now starts to develop that reassociation of the bed as a place to mentally relax, shut down, and get to sleep. Now, there's another common principle that we'll utilize in cognitive behavioral therapy for insomnia as well, called sleep restriction therapy. Now, sleep restriction therapy is a very powerful principle that works really, really well. And in essence, the core of it is that we're basically having individuals temporarily truncate how much time they're actually allowed in bed. Another common thing that people with chronic insomnia will do is that, gosh, you know what? I used to go to bed at 9 o'clock in the evening and I'd fall asleep within 10 minutes and my alarm would go off at 4 in the morning and I got my 7 hours of sleep and I felt great. Then I started developing insomnia issues and gosh, you know what? I'm lucky if I get 4 or 5 hours of sleep if I go to bed at 9 and wake up at 4. So now, because I have to wake up at 4, now I'll get into bed at 7 p.m., right? So I'm hoping that if I'm in bed longer, hopefully I'll be able to get more sleep that way, right? So they're giving themselves a greater opportunity to sleep in hopes that they'll get more sleep kind of in that, 9-hour window. But what ends up happening is that this again self perpetuates the chronic insomnia. There's a phenomenon called the sleep drive, right? Or process S, as we officially call it. And what this states is that there's a homeostatic pressure for sleep that builds up throughout the day. So as the day goes on, we're usually the most awake when we first wake in the morning. And then the level of wakefulness kind of gradually declines as the day goes on. There's usually a dip that we call a circadian dip between 1 and 3 p.m., which is a common time for people to feel fatigued, during that window, especially after lunch, which can be accentuated if a person isn't getting good quality sleep at night or if they're sleep deprived. Like for me, I sleep 7 hours, 7 hours, 20 minutes. I wear my BiPAP all night long. I don't feel the fatigue, after lunch or between 1 and 3 p.m. Now, if I'm sleep deprived or if I slept poorly the night before, I definitely can notice tiredness between that 1 and 3 p.m. window. Now, let me get back to this, homeostatic drive for sleep. So that process S, basically, as the day goes on, we start building up this pressure for sleep, right? And as we get closer and closer to bedtime, now our brain has developed such a large pressure for sleep because the last time we actually slept was almost 12, 14, 16 hours ago, that this pressure for sleep actually helps us to be able to get to sleep. That combined with process C, which is our circadian rhythm, when these two match up, then this helps us to get to sleep and stay asleep. Now, when a person spends too much time in bed, in the setting of chronic insomnia, they may doze off at 8 p.m. for half an hour, and then they are awake again for an hour. Then they may doze off at 9 o'clock for an hour. Then they may wake up, 3 hours later, and then they're awake for an hour and they go back to sleep. So you can see that sleep becomes very choppy. So what ends up happening is that the pressure for sleep actually drops pretty markedly because they dozed off at a time that their brain isn't set for them to go to sleep. But that in turn then causes the insomnia to continue to perpetuate. So their sleep problem continues to kind of feel itself by virtue of getting into bed much earlier than they should. Same principle or concept occurs in the setting of napping, right? When we advise individuals to help kind of improve their overall sleep picture in the setting of chronic insomnia, we'll also advise people not to nap. And what our official rule is for napping is we don't want individuals to nap for any longer than 30 minutes. And we want the nap to be before ideally 2 p.m., right? 2 to 3 p.m. The reason for it is that if you nap before 2 to 3 p.m. and the nap is shorter than 30 minutes, well, then this won't disrupt that sleep drive or that pressure that we're building up for sleep as the day progresses. If you end up dozing off watching TV after dinner for an hour, say at 7 p.m., and then you wake up and you're awake for another hour or two, well, then that starts disrupting your sleep drive, right? So a lot of these individuals will say, I can't fall asleep now because, I fell asleep in front of the TV for an hour. I wake up and then I go to bed, but now I'm laying there awake for an hour. So one of the things we'll advise people is we'll try to avoid napping, which is obviously an intuitive thing to say. But we'll even temporarily tell people that, you know what, you could go to sleep a little bit earlier. But then obviously set your alarm to where you wake up 7 hours later. Don't allow yourself to lay in bed for 9 hours. But then there's other individuals that may have a circadian rhythm disorder called advanced sleep phase disorder. I met a gentleman in clinic the other day where I'm managing his Inspire implant, which is the hypoglossal nerve stimulator for obstructive sleep apnea. But I hadn't seen him in 6 months because he's doing really well from a sleep apnea standpoint using the Inspire implant, but he's had insomnia issues, all along. And I've tried addressing it. I've given him recommendations, but again, I went through kind of a sleep history with him when I was meeting him a month ago. And in essence, what turns out is that he's 78 years old, I believe. And in essence, what's happening is that he has dinner with his wife around 6:30 p.m. Then he sits in front of the TV around 7:30 p.m. and he will fall asleep, for about an hour, hour and a half. And then he gets up and tries to go to bed. And now he's awake for an hour when he goes to bed. And he calls his bedtime to be around 9 to 10 p.m. But then he consistently wakes around 3 to 3:30 a.m., sometimes 4 a.m., right? So 3 to 4 a.m. is his time that he always wakes up. Now, he told me when I asked him, what happens if you stay up later? He's like, well, if we go out with friends and have a dinner party and I don't go to bed until 11, I still will always wake up between 3 and 4 o'clock in the morning, like clockwork, right? So in my mind, I'd already advised him this 6 months ago, but he didn't follow the instructions. But what I explained to him after I kind of went through multiple different things, he even worked with one of our sleep psychologists for a short period of time. But what I advised him 6 months ago and even recently was, given his age, he's at a higher risk of having a circadian rhythm disorder called advanced sleep phase disorder. What that means is basically his sleep window is shifted earlier in time rather than my time, say 9 p.m. to 4 a.m., or others where they're 10 to 5 or 10 to 6. So in his picture, it appears that his circadian rhythm has shifted to an earlier time point where his intrinsic bedtime probably is closer to about 7:38 p.m., meaning that's the time that his brain is set for him to go to sleep. And his natural wake time, which adds 7 hours to that, is probably around 3 to 3:30 a.m., right? So that's his natural sleep window. So what I had asked him to do, and I'd asked him to do this before, but he didn't do it. But I asked him this time, I was like, let's wholeheartedly kind of approach this, scientifically. What I advised him was that I want you to temporarily go to bed, eat dinner around 5:36 and then go to bed around 7:38. I don't want you to watch TV. Go for a walk in the evening so you avoid that opportunity to accidentally doze off watching TV in the living room. But I want you to go for a walk in the evening after dinner. And then I want you to go to bed around 7:38 p.m., right? And let's see over the course of a week what happens. If he's falling asleep within 30 minutes or less, going to bed earlier, and he's sleeping through the night and then waking up around 3:30 in the morning, and he's been able to achieve that consistently for at least a week or longer, well, that shows me that his intrinsic sleep wake schedule actually is 8 to 3, right? Or 8 to 3:30, which is a 7 to 7.5 hour sleep window. So that's what we call advanced sleep phase disorder. Is there a way to correct that? Like, for instance, if you said, well, ideally, I'd like to be able to stay up till 9 o'clock, and go to bed at the same time as my wife and then wake up, say, around 4 o'clock in the morning. Well, the way to approach that would be to expose himself, to a little blue wavelength light or a bright light in the evening. Can't get sunlight that late, so that you can get a light box, which I advised him from Amazon, where he can spend, about half an hour to an hour in front of this light box, about an hour or two before he ideally wants to be asleep. And what ends up happening when you expose yourself to the blue wavelength light in the evening like that, it actually delays our circadian rhythm, right? Or it pushes our internal clock later in time. So that now kind of leads into another circadian rhythm, which is a common cause of problems falling asleep, called delayed sleep phase disorder. So this is probably the most common circadian rhythm disorder that we'll see in our clinics. Delayed sleep phase disorder is the opposite situation, where an individual's brain is set for them to be a night owl, where, for instance, individual's brain is set for them to go to bed at 1 o'clock in the morning and naturally wake up at 8 o'clock or 8:30, which is a 7 to 7.5 hour sleep window. But because of school, work, or other obligations, they need to go to sleep, at 10 so they can be up at 5. Now, there's a significant mismatch there, right? There's a 3-hour difference from the time that they want to go to sleep and the time that the brain is set to go to sleep, right? But invariably, they don't fall asleep until 1 o'clock in the morning, and then their alarm goes off at 5 o'clock in the morning. So now they've only slept 4 hours, right? So they're exhausted when they wake in the morning. They're exhausted during the daytime. They've got those daytime symptoms as well. Now, what's a common What are common risk factors for individuals developing the circadian rhythm disorder? Well, a big one, obviously, for the last 20 years, if not a little bit longer, is just exposure to electronics in the evening, right? Whether it's video games, iPhones, smartphones, iPads, you name it, right? That blue wavelength light that we're exposing ourselves to in the evenings actually inhibits melatonin release, right? That's why we're all day people in the sense that when our eyes and the retina detect blue wavelength light from the sun in the morning, that in turn then inhibits melatonin production. So it turns off the sleep hormone. So then the brain knows that it's time to wake up. Well, you shouldn't be exposing yourself to artificial sun, so to speak, in the evenings, right? But individuals that end up spending time in front of the computer or in front of color screens for hours on end in the evenings have a tendency to delay their circadian rhythm. We see this a lot in individuals in the IT industry, computer programmers, developers, because they often do a lot of work late at night when there's no other distractions. Gamers, we'll see this a lot in. We see it a lot in our young generations as well because they were born into this world with all these electronics. So we see this a lot. We even see it run in families as well, and it's not necessarily genetic, but it's actually observational, right? If the parents aren't going to bed until midnight, 1 o'clock in the morning, well, to them, going to sleep, earlier than that, it's odd, right? It's not normal for them. So invariably what happens is they don't put their kids to sleep until 10, 11 o'clock at night. I mean, now, and the kids are waking up, even though the child's circadian rhythm isn't delayed, the child is waking up around 7 o'clock in the morning, but they've only gotten 6, 7 hours of sleep. And young children obviously need a lot more sleep than that. So that leads into a whole nother slew of issues with hyperactivity, ADHD, all that sort of stuff in children. But because the parents don't realize that the child actually needs more sleep and they should be going to sleep earlier, these children, as they get older, they start developing delayed sleep phase disorder as well. So it was a product of their environment, right? So that's how it can kind of run in families. So now getting back to our kind of scenario in terms of that's the other most common circadian rhythm disorder that we'll see, or the most common circadian rhythm disorder that we'll see. We'll have individuals that'll come in saying, "Hey, I need to be asleep by 10 or 10:30, and I need to wake up at 5." But I'm laying there wide awake with my mind racing for hours before I finally fall asleep. And come 1 o'clock in the morning, I fall asleep. Well, one of the easy ways that we'll kind of figure out if a person has this delayed sleep phase disorder is we'll ask, well, what happens on the weekends? What happens when you don't have to set an alarm to wake up at 5 o'clock in the morning? What time would you naturally wake up, regardless of what time you went to bed? And 9 times out of 10, these individuals with delayed sleep phase disorder will basically naturally wake up 7 to 8 hours later than when compared to when they initially dozed off naturally, right? Not what time they went to bed to try to go to sleep, but the time that they actually naturally fell asleep. So in this patient example, goes to bed at 10 o'clock. Natural bedtime is 1 o'clock. If they don't have to wake up in the morning, they'll say that, hey, you know what? If I get to sleep in, I can wake up anywhere between 8 and 9 o'clock in the morning. So they've gotten their, 7 to 8 hour sleep window, but yet they spent, up to 12 hours in bed. Now, that's one of the ways that we'll determine. Another way that we can also determine using some objective information is a device called actigraphy, where basically it's kind of like a sleep tracker that measures motion, kind of what sleep trackers today kind of use as motion, but we'll send the patient home with that plus a sleep diary for a few weeks. And we'll use the data from the actigraph compared with their sleep diary to kind of determine what does their kind of sleep window typically look like. So that's a very common cause of difficulty falling asleep that often is missed, right? And it's missed not because the patient doesn't have it, but it's missed because time wasn't taken to kind of decipher what exactly is going on, right? And most non-sleep physicians don't know that there's a common, sleep disorder that causes insomnia called called delayed sleep phase disorder. But it's a very, very common cause of people having a hard time falling asleep. And it's easily correctable as well, right? You can use light exposure, but melatonin as well temporarily, and then gradual advancement of the circadian rhythm where we gradually pull your internal clock earlier in time. And there's a whole way to do it. And it's often, in our practice, we'll have our patients with delayed sleep phase disorder work with our sleep psychologists to do progressive advancement of their circadian rhythm to get them to a point where they're now naturally falling asleep without having to take anything at 10:30, and they're now naturally waking up at 5 in the morning or 5:30 in the morning. So we can actually reset the circadian rhythm to match the time that they would ideally like to fall asleep and ideally they would like to wake up. So now they're no longer sleep deprived and not having those daytime symptoms. Okay, so I hope that kind of helps to kind of explain some of the common insomnia conditions that can present with difficulty falling asleep or staying asleep. Now, what are other sleep disorders that can present with insomnia symptoms? So, one is going to be restless leg syndrome. So, restless leg syndrome is a very unique condition. It's a sleep disorder, but it only occurs when a person's awake, right? My wife has it really badly. In essence, what happens is when the individual is laying in bed in the evening times, when it's close to, the time to go to sleep, they may experience an achiness in their legs. And most individuals kind of will preface when they're trying to describe how it feels, they'll usually will say, it's really hard to describe what it feels like, but I feel this kind of deep achiness. I may feel a creepy crawly sensation, or I just feel this internal sensation that I just have to move, right? And when these individuals will stretch or get up and move or walk around, that uncomfortable sensation actually temporarily resolves. When they get back into bed, after a few minutes, it may come back again. So, in essence, what's happening is that they're chasing after this discomfort. So, they're having to get out of bed, stretch, walk around. Movement actually temporarily kind of eliminates the discomfort. But then when they get back into bed, it comes back again. So, they're just going in and out, in and out, in and out. And it can last for hours. And then eventually they'll just exhaust themselves and then they'll finally just crash and fall asleep, right? Individuals with restless leg syndrome can also experience the symptoms in the middle of the night. So if something wakes them in the middle of the night, then they can start experiencing these symptoms. Now it takes them 2 hours to be able to get back to sleep. They just end up exhausting themselves and they just crash, right? So this is a very common symptom of chronic insomnia as well. And it's one that has to be asked because it's more prevalent than you realize. Now, individuals don't realize it. Like I had a patient that I met, 10 years ago. And she was in her late 40s at the time. And she had chronic difficulty falling asleep, right? And that was always her history is I can't fall asleep. And she had been prescribed multiple different sleep aids over the years by primary care physicians in order to help her to fall asleep. And one of the things that she had said was, you know, I just feel restless. So I have to get up and I usually go for a run. So she was an avid runner, but she would usually run in the evenings and she would probably go run like 5 to 10 miles in the evenings just to tire her body out. So that way, when she came home, she'd shower and she'd crash and fall asleep. Right. But then I asked her when I met with her, as I was going through her consultation and asking her the different sleep symptom questions. So I asked her, I said, what happens if you don't go for a run? Do you experience any kind of strange symptoms? She goes, yeah, like there's times when, I'm traveling and I can't go for a run and I'm laying in bed and trying to fall asleep. It just, my legs ache and they just feel restless. And I just got to get up and stretch and walk around and I just can't relax. I can't relax to fall asleep. That's why when I go run, my body's exhausted by the time I come back and I'm able to crash and fall asleep. Well, it turned out that all along, all these years, her problem falling asleep wasn't the result of anxiety. It wasn't the result of depression. It wasn't the result of a conditioned response, meaning that she had self-perpetuated her brain to not want to fall asleep quickly. It actually turned out that she had undiagnosed restless leg syndrome. But she didn't realize what restless leg syndrome was, and she didn't realize what she was experiencing was actually a sleep disorder. So in her case, I worked her up. I assessed her ferritin level, put her on iron supplements, vitamin D supplements. And long story short, I treated her for restless leg syndrome rather than for chronic insomnia. And by virtue of treating her for restless leg syndrome, now if she didn't go for a run, she was falling asleep within half an hour or less because she wasn't experiencing the symptoms of RLS. But you can see that in this patient, she went for 20 years being diagnosed as a chronic insomniac, but it turned out that her chronic insomnia was not a primary diagnosis. It actually was secondary to chronic restless leg syndrome that had never been diagnosed and treated before. So Restless leg syndrome is a very common cause of difficulty falling asleep or difficulty getting back to sleep in the middle of the night. A related condition, like I alluded to earlier, is what we call periodic limb movements during sleep. Up to 70% of people with restless leg syndrome can actually have this condition. Also, it can coexist in the setting of sleep apnea as well. In essence, what happens is an individual, while they're sleeping, they'll get repetitive, periodic kind of flexion type movements of either the toes or the foot or even the leg. And it's usually the outer shin muscle called the anterior tibialis muscle that's actually contracting, and it triggers these movements. Now, these movements don't always disrupt sleep, but in individuals that have significant periodic limb movements during sleep, those movements may actually trigger the person to wake back up again. I don't think we fully understand how the movements trigger the person to wake up because they're not huge movements that a bed partner would feel them and they would wake up as well. And they could be as subtle. I mean, they could be as subtle as just almost like just lightly rubbing your heel against the bed sheet. And some people will actually rub holes into the bed sheets because of just that constant rubbing. But that subtle movement will wake the person up and multiple times throughout the night. So it can cause very fragmented sleep where they're just tossing and turning, tossing and turning. Like my wife has it. You know, she has restless leg syndrome and she's lucky enough to have periodic limb movements during sleep as well. So if it's not one or it's the other that's affecting her sleep, mind you, she's on treatment, so she's overall doing well. But she can either have a hard time falling asleep because of restless leg syndrome. Common trigger in her situation is being, up on her feet all day long, especially if we were to go, we're on vacation and we walk a lot, or if we go to a concert or a music festival and we're on our feet all day long, that usually has a tendency to aggravate her restless leg syndrome symptoms. Or if she's not taking iron supplements, that will also aggravate it as well. But once she falls asleep, she can have these repetitive movements or twitching, which will in turn wake her up, right? And there's been times where the periodic limb movements would wake her in the middle of the night, and then her RLS symptoms would then prevent her from getting back to sleep. So as you can see, it's easily possible for a person to become sleep deprived and have problems sleeping the next day. So periodic limb movements during sleep is a common cause for disrupting sleep. Now, sleep apnea. Sleep apnea is a very, very, very notorious disorder or sleep disorder for causing insomnia symptoms. So when we meet a patient in clinic with symptoms of chronic insomnia, we have to always consider, could sleep apnea be causing this problem's insomnia symptoms or be partly responsible for it. Now, how does sleep apnea cause problems sleeping or cause chronic insomnia? Well, in a lot of female patients and postmenopausal patients, we will see sleep apnea actually present as difficulty falling asleep. And you wouldn't think it, right? But it actually can happen. And we've seen it before during sleep studies. And in essence, what's happening is that as the individual starts to drift off, as soon as the brain goes into stage 1 or stage 2 sleep, typically stage 1 in the early part of the night, muscles in the body relax, right? It's like almost like switches, right? So the brain goes into stage 1, muscles relax. Stage 2, muscles relax. Well, remember, sleep apnea is a condition where the tongue itself falls back, the soft palate relaxes, and basically the airway up in the back here kind of obstructs either partially or completely. Well, what happens is that as the airway diameter declines, if the individual can't fully release their carbon dioxide, that spike in carbon dioxide is the cue for the brain to know that the person isn't breathing normally. So the immediate response is to wake up. So in the setting of difficulty falling asleep triggered by sleep apnea, what in essence is happening is that the person may go to bed at 10 o'clock and they may fall asleep within 10 minutes, but then in those few minutes of sleep, they have a subtle sleep apnea event that doesn't cause them to gasp or, stop breathing, but just a subtle collapse to where they have a little bit of CO2 retention and the brain quickly wakes back up again. And now they're awake for half an hour, 45 minutes. Then they drift back off asleep again for a few minutes, and this occurs all over again. So in essence, what they're doing, they're just kind of lightly tapping sleep, but then they're laying awake for prolonged periods of time between the times that they're actually dozing off. But they initially fell asleep within 10 minutes, which is by definition normal. So they don't truly have a problem falling asleep. But what's happening is that in the first hour, hour and a half, typically the first hour, it can be difficult for the brain to be able to progress past stage 1 sleep into stage 2 sleep and then into stage 3 sleep, meaning it can be harder for the sleep to consolidate itself to keep a person asleep even after it wakes up quickly in the background for a sleep apnea event, for instance. So the person's just kind of lightly drifting in and out of sleep. Now, ask yourself this question. How do you know that you slept last night? Do you actually remember sleep, or do you remember the time that you went to sleep and then the time that you actually woke up the next morning, right? None of us can actually truly remember sleep, right? There's no way, because when we're asleep, there's no memory of it, right? The way we actually conclude that we slept is by deductive reasoning. So for me, for instance, the last thing I remember before I closed my eyes last night, my phone read, I think it was probably 9:35, right? The next thing I remember when I reflect back on last night, the only thing I can remember is my alarm going off at 4:05, because I remember seeing a timestamp on my phone saying 4:05, and I hit snooze for 10 minutes. When I reflect back, I don't think I remember anything from 9:34 all the way until 4:05. So I assume that I was asleep the entire time, right? That's how we all conclude that we slept, is that you don't have a recollection of a period of time during the night. Now, individuals that have chronic insomnia, they have recollection of different timestamps, right? And naturally, people will start to overestimate how much they were awake and overlook the fact that they were actually asleep. And that's just human nature. It's intrinsic. It happens, right? Because again, we can't remember sleep itself. So, getting back to the sleep apnea and difficulty falling asleep part, these individuals won't recognize that they actually fell asleep in 10 minutes for a few minutes, and they're awake again for 30 to 45 minutes, and they dozed off again for 10 minutes, and then they were awake again for half an hour, right? So their brains will overlook the fact that they had a few minutes of sleep here, a few minutes of sleep here, a few minutes of sleep here. Their brains have a tendency to just recall those periods of time that they were actually awake. So in their minds, they'll come in saying, "It takes me 2 hours to fall asleep. I don't drift off to sleep at all," right? And there's different ways that we can actually measure this, but one of the tools that I use basically is home EEG, where I can record a person's brain activity at home, and that's when I will see over the course of 3 nights that, you know what, this person's brain actually is drifting off to sleep in a normal amount of time, but then they're awake for these long segments, but not continuously awake for 2 hours, right? It's a very broken sleep. So that kind of clues us in that, is there something that's actually disrupting sleep, right? So that's a common cause for individuals having difficulty falling asleep in the setting of undiagnosed sleep apnea. And we usually will see this most commonly in female patients, especially postmenopausal patients. And once you treat the sleep apnea, now the airway is being kept open, whether it's with CPAP or an oral appliance or Inspire therapy for those that can't tolerate CPAP therapy. Now there's no trigger for the brain to have to wake back up again soon after dozing off, because there's no retention of carbon dioxide because the airway is being kept open. So now the person's falling asleep in 10 minutes. Now they're sleeping through the night, right? Without the need for any kind of prescription sleep aid or anything. And it's also concerning because a lot of these individuals, by the time they come to us, they've been having this issue for years. It's not a new issue, right? So they've already been prescribed Ambien, temazepam, trazodone, melatonin, you name it, right? They've already taken all these prescription sleep aids and over-the-counter sleep aids, but they still haven't had resolution because, in essence, they were actually trying to treat a symptom of an underlying sleep disorder. If the brain has to wake up to get you to breathe, the brain's going to wake you up to get you to breathe, even if you're taking, a sedative medication. Unless you're taking a high dose that you shouldn't be, the brain typically will wake up. So that's how sleep apnea can cause problems falling asleep. Now, sleep apnea is a extremely notorious cause for difficulty staying asleep. Again, same concept. If the brain detects that you haven't taken a normal breath because you have retention of carbon dioxide, the brain's immediate response is to wake up. The brain can't change the way we breathe and keep us asleep at the same time. So the brain has to wake you up. Again, brain wakes up, you take a couple of normal breaths, the brain goes back to sleep, airway muscles relax again, and this whole thing occurs all over again. Now, obviously, when you get past that initial 60-minute mark of sleep, then your brain is going to be spending more time in stage 2, stage 3, and REM sleep. And when that happens, the brain's able to take you back into sleep much faster than it would have been in the prior scenario where the person was having a problem falling asleep because the brain couldn't keep you asleep very well because it was just hovering in stage 1 sleep. But the other thing too is that sleep apnea can even cause what we call early morning awakening, or that terminal insomnia that I referenced earlier, where an individual wakes up, at least 30 minutes earlier than when their desired wake time is. Sleep apnea is a common cause of that as well. Reason being is that we'll go back into kind of sleep architecture, right? Which is the various levels of sleep and when we spend time in those various levels of sleep. REM sleep is a period that we call rapid eye movement sleep. That's the period of the night that our brains are dreaming. That's also a period of the time where the airway muscles and the muscles in the body are very relaxed. Technically, skeletal muscles are paralyzed, but the throat muscles are much more relaxed. So, in the setting of sleep apnea, individuals can have more frequent sleep apnea events. Individuals can snore much louder when they're in REM sleep. Now, in terms of timing of REM sleep, we technically have REM sleep kind of scattered throughout the night, right? Ideally, we should have about 4 to 5 different sleep cycles where we start out in stage one, go to stage two, go to stage three, and then terminate a sleep cycle in REM. And as the night progresses, stage three sleep basically drops off after the first third of the night, and then REM sleep dominates the end of the sleep cycle. And each period of REM sleep progressively gets longer and longer as the night goes on, where our longest episode of REM sleep is typically within 2 hours of our habitual wake time. So, getting back to sleep apnea, individuals, when they enter into that window of REM sleep in the early morning hours, because there's increased muscle relaxation in the airway, if a person has a sleep apnea event, the brain will quickly wake up in REM sleep. And even though REM sleep technically is a deep level sleep, when we wake out of REM sleep, we actually can feel fully alert and fully awake and rested as if it's time to get up and go, but it's 3 o'clock in the morning. Then the person, if they're not able to turn off their mind, they have a problem getting back to sleep, like I talked about earlier. But one of the ways that I will kind of determine if this could be potentially sleep apnea related, meaning the early morning awakening, I'll ask the person, hey, when you wake up at 3:30 in the morning, do you recall even a snippet of a dream, right? If they say, yeah, you know what, I often will remember waking at that time and having remembered a dream or a nightmare, well, that tells me right off the bat that this person is waking out of REM sleep. Because the only way that we actually will remember a dream or a nightmare, which is just basically a bad dream, is that we come to conscious awareness or conscious arousal out of REM sleep itself, right? So that is one clue to me to tell me that, hey, this person's early morning awakening could be the result of more significant REM related sleep apnea. So that's another common way to decipher if that early morning awakening is a result of true chronic insomnia, as I defined earlier, or if it's secondary to underlying sleep apnea. Another common clue to let us know that, hey, this person's problem, difficulty staying asleep, is a result of sleep apnea, or could be the result of sleep apnea, is asking, do you recall dreams regularly? If a person says, no, I don't really recall dreams very often, that doesn't exclude sleep apnea from being a potential, diagnosis or contributor to the problem falling asleep. Because in that scenario, if the brain's waking up excessively in the background, that ends up shifting the brain to spend much more time in lighter sleep. So the brain really isn't getting much time in REM sleep. So there's very little opportunity for the person to have a conscious arousal in the middle of REM sleep to remember a dream. But on the flip side, individuals may report, gosh, I'm a very vivid dreamer. I can remember 3, 4 different dreams, and it feels like, I'm just living them and they're very vivid, they're exciting. And I can, when I wake up and I can tell the whole story about what happened. So, what that tells me is that the individual is waking up very frequently in REM sleep, right? And when dreams are reported to be very vivid, in essence, what's happening in that single REM period, the person is coming to conscious arousal, even or conscious awareness very briefly, but several times throughout that REM period, that in essence, they're getting snapshots of recollection of different segments of that story or that dream. So in their mind, their brains will piece all of those little segments together into one long segment. So now they're reporting, hey, I had a very vivid dream. It was almost like living in a real life movie. But that's another clue to us that this person may have significant upper airway muscle relaxation, causes significant sleep apnea, and it's frequent sleep apnea events during REM sleep that's triggering that person to have those frequent dream recollections, right? So that's another way that we can kind of clue in to say, hey, maybe sleep apnea could be on the table here, and that could be causing this problem's chronic insomnia. So that's the reason why if you see a sleep specialist, that's the reason why we always consider sleep apnea as a potential cause of the person's insomnia. We have to rule it out, right? Sleep apnea is a significant contributor to cardiovascular issues, stroke, Alzheimer's disease, and up to 25% of people with sleep apnea actually don't snore, right? So you don't have to snore to have sleep apnea. That's why we always have to consider it. And if it's not there, great. Then we know that it's not sleep apnea related. So one of the ways we have to approach a person with chronic insomnia is that we kind of have to rule out everything else, right? We rule out other sleep disorders that could mimic insomnia. We got to look at other medical conditions that could be presenting with insomnia. We have to look at mental health, right? We'll have a lot of patients that will come in with chronic insomnia symptoms that have untreated, uncontrolled depression, undiagnosed or uncontrolled generalized anxiety disorder. PTSD, chronic PTSD is a common cause of chronic insomnia. And they have uncontrolled PTSD. So there are times where we'll have to recommend that, hey, we recognize that you have this chronic insomnia, but based upon our assessment, your chronic insomnia actually is secondary to this mental health issue, right? Whether it's depression, anxiety, PTSD, bipolar. So from our recommendation would be you need to get that primary condition under control. And by getting it under control, it should help to control insomnia, right? We can't control the insomnia first without controlling that because it's the depression, anxiety, PTSD that's actually causing your insomnia. Same concept when it comes to medical conditions, right? Chronic pain is a big one that we'll see. People have a lot of sleep issues related to chronic pain. And I met with a patient just last week, in fact, who's again another Inspire patient. And she's been doing well, but she decided that she wanted to wean off Cymbalta that she was being prescribed for her fibromyalgia and her chronic pain that she's had for 30, 40 years. Mind you, she's about 75 years old. Well, she decided she didn't want to take the medication anymore. I'm not sure if she spoke to her physician that was prescribing it, but she gradually weaned herself off of it. And when I last saw her a year ago, she was actually doing well from a sleep perspective. Actually, in fact, when I saw her 6 months ago, she was doing well. But mind you, she was still taking Cymbalta and she wasn't having chronic pain issues. Last week when I met with her, her biggest complaint was that she's just hurting all the time and her sleep is just horrible because she just can't get comfortable. Her shoulders hurt, her hip hurts, her knee hurts, her whole body just aches. And one of the things I had to review with her was, well, you realize that the Cymbalta that you were taking was very likely being prescribed to help with your fibromyalgia and your chronic pain. And she had forgotten about that, right? She thought it was just for her mood. And she goes, my mood is great, except for I'm not sleeping well because of my pain. So I advise her that there's not much I can do for your insomnia right now because it appears to be all related to your chronic pain and your uncontrolled pain. So you really need to, speak to your primary care physician or even a pain specialist to get your pain under better control, which in turn is going to help her sleep, right? So that's the way we kind of approach insomnia. Now, if when we are going through our assessment, there isn't medications, there isn't a medical condition, neurological condition, mental health disorder that could be causing this problem, person's insomnia, or there's not another sleep disorder that could be causing this person's insomnia, and we then conclude that, you know what, this is pure classical and chronic insomnia, that's when we'll kind of say, all right, this is how we're going to approach it. And the first line treatment recommendation is cognitive behavioral therapy for insomnia, which I kind of already went through some of those concepts earlier. But I'll kind of follow up on on a concept that I had mentioned, but I didn't, kind of go through the whole concept of it. But cognitive behavioral therapy for insomnia is geared towards basically restructuring individuals' cognitions because a lot of people that develop chronic insomnia will say, I can't sleep, or my brain has forgotten how to sleep. I've met people that as they're driving home in the evenings, as 5, 6 o'clock approaches, they already start thinking about their sleep, even though they don't go to bed till 10 o'clock at night. They start getting anxious and worried and nervous that, gosh, I'm not going to be able to fall asleep. But it's only 5 o'clock. They haven't even had dinner yet. They haven't even gotten home. I've had, individuals say that my bed is my death trap. I'll never sleep. I had a patient that I met a few years back during the pandemic with chronic insomnia. And she said that she absolutely cannot fall asleep in her bed. What she does, she goes in her closet, lays on the floor, and she'll fall asleep. And that was a classic example of her brain has developed an association with her bed as being a place to lay awake, but her brain has not developed that association with the floor in her closet. So when she lays down in her floor in her closet, she's able to fall asleep quickly. And that just shows that her brain has developed an association of the closet floor being a place to sleep, but the bed is not a place to sleep, right? And so cognitive behavioral therapy for insomnia is geared towards identifying all these little, cognitive associations and all these negative associations towards sleep and basically kind of coaching the individual out of those negative thoughts towards sleep and trying to get them away from putting sleep on this huge, pinnacle where they can't achieve it rather than thinking that, all right, sleep is something that's intrinsic. My brain knows how to get sleep. It hasn't forgotten how to get sleep. The whole chemical process of sleep is still occurring. It's just psychologically, I have forgotten what it was like not to think about sleeping. But then the principle of stimulus control, like I educated you on earlier, but then sleep restriction therapy. And we'll come back to the sleep restriction therapy now. So sleep restriction therapy is a uh, very common principle in CBTI, and it's a very powerful effect. In terms of what we're doing, is that we're basically temporarily shortening a person's sleep window. So remember, I had referenced earlier a person that goes to bed at naturally goes to bed at 1 o'clock and naturally wakes up at 7, but they are wanting to go to bed at 10 and they're not able to get to sleep for several hours, or the individual that, can't fall asleep because of acute stressors and their mind's just racing for 2 hours and then they wake up, 5 hours later, but it took them 2 hours to fall asleep. What we'll have them do is that we'll tell them that, all right, temporarily, we want you to go to bed at midnight and wake up every morning at 5 o'clock in the morning, right? Yes, you're going to be tired when you wake in the morning, but what we're trying to do is basically we're trying to push your brain past the time that it's typically set to go to sleep, which is probably around 10 o'clock. But we want to force your brain to stay up past that. So by the time you get into bed at midnight, your brain is so exhausted that the thought being is that you'll fall asleep very quickly. You'll sleep for 5 hours and then you'll wake up at 5 o'clock in the morning. We don't want you to nap during the daytime because we want to put you into a temporary state of sleep deprivation. And you repeat this process, every single night for the next week to 10 days. So we're building up this a higher pressure for sleep. So we're actually increasing that homeostatic sleep drive, or that process S, by inducing this, you know, state of sleep deprivation. And then as you build up this pressure for sleep, then we'll have you gradually go to bed, say in 15, 20-minute increments earlier, once a week. So then you can slowly release some of that pressure. Now, by this point, you've kind of developed that confidence that, hey, you know what? I'm falling asleep super quickly. I'm exhausted when I get into bed. I'm sleeping for 5 hours. Even though I'm tired the next day because I'm sleep deprived, I'm still at least falling asleep rapidly. So you start building up this positive, this positive reinforcement. You build up this confidence to where, all right, gosh, you know what? I can get around this. I will be able to correct my insomnia. So then what we'll have you do is that, all right, for the next week now, we want you to go to bed at 11:40, but still wake up at 5 a.m. As long as you're falling asleep within 20 or 30 minutes. Then the following week, say, all right, now we want you to go to bed at 11:20 p.m., wake up at 5 a.m. So you get my drift. And that will just gradually advance your bedtime by about 20-minute increments until we can slowly inch you back to a bedtime of 10 p.m., to where you're falling asleep within half an hour, sleeping through the night, albeit there's no other factors that could disrupt your sleep. And then you're waking up at 5 a.m., right? And by expanding your sleep window to 7 hours, and we're advising you, we don't want you to spend any more time in bed than about 7 to 7.5 hours. That should correct your insomnia and you should feel better the next day. So, sleep restriction is a very, very powerful concept and it works really, really well, but you have to be very diligent about it. If, for instance, you are doing a sleep restriction and then you go on vacation and you're like, forget it. You know what? I'm on vacation. I'm not going to follow this. And you allow yourself to sleep in or you stay up late, for whatever reason, you don't follow this prescribed sleep-wake schedule, temporarily your brain reverts right back to where you started. So you kind of have to start all over again. So it's important that if you engage in a sleep restriction, that you follow through with it and basically reset. So point being is that CBTI can truly work to correct an individual's chronic insomnia. But again, we have to make sure that there's no mental health disorders, medical conditions, neurological conditions, medications, or other sleep disorders that could be mimicking chronic insomnia, right? So CBTI is not going to work well in individuals that have a primary cause of their insomnia. So we have to rule all those things out and then conclude that, all right, there's nothing else, right? So that's why when we meet with a patient with chronic insomnia, it's not a matter of, okay, you've got chronic insomnia, we're going to do XYZ and here you go, or here's a prescription for Ambien. It's not that simple, right? For us as sleep specialists, we're trying to get to the root issue of what's going on after we determine what are your true symptoms, right? And then once we identify what the root issue or issues are, then we treat there, right? That's how we address it. So we're trying to uncover what's the etiology or etiologies. Once we identify those, then we want to tackle those. And that in turn will correct the insomnia. Because like I said earlier, insomnia can be symptoms of many other things, right? So insomnia to some degree is also just a broad term as well, kind of like pain. So I hope this kind of helps to better clarify how we as sleep specialists approach insomnia. What is the definition of chronic insomnia? What are other kind of factors that could predispose you to having chronic insomnia or developing chronic insomnia? What are other conditions or medications or sleep disorders that can present with insomnia symptoms, but you don't truly have primary insomnia? But ultimately, if you're not sleeping well, you're concerned about your sleep tracker is showing that your sleep is very broken. You have, symptoms of tiredness, poor focus, concentration. You're not able to function at the high level that you're accustomed to. You're having unexplained weight gain or difficulty losing weight, or you're having, changes in your mood. I highly recommend that you seek out a sleep specialist to be able to figure out what is going on with my sleep. Why am I not sleeping well? Why am I having insomnia symptoms? What exactly can I do to be able to correct my sleep? Because as we now know, sleep is very, very important, right? And we spend a third of our life sleeping, and you know, the higher being that built us all designed us to be able to do that. That's the time when the brain is able to cleanse itself, right? The brain functions all day long. It uses stage 3 sleep or deep sleep to be able to kind of turn on that, dishwasher mechanism to wash out toxins that build up during the daytime. So it mitigates our future risk of developing Alzheimer's disease or dementia. Various different organs have different regenerative functions when we sleep, right? Cardiovascular function also is dependent upon sleep as well. And the heart's also dependent upon getting good quality sleep as well and sufficient duration of sleep. So there's a multitude of reasons from a longevity perspective that it's important that we're getting the most optimal quality of sleep and the most optimal quantity of sleep, right? So don't neglect your sleep because it's a simple thing to be able to address and correct. You just got to take the time, seek out a sleep specialist to be able to get to the root of the issue and figure it out. Everybody feels great when they get great sleep, right? I hear that all the time. Even if I'm not in clinic, I'm traveling and I tell people that I'm a sleep physician, like, oh man, I don't sleep well, or gosh, when I get a great sleep, I feel so much better, right? So everyone can relate to this. So point being, if you're not sleeping well, go seek out, professional help and guidance to be able to get your sleep issues corrected and resolved so you can have a better life during the day and live a longer life. So, all right, take care.